Well, I want to start off by just thanking all of our speakers for really outstanding presentations. I thought they were all really excellent and thought-provoking. And I want to start off by thinking a little bit about the future of the field and ask each of you to comment a bit on, we've heard about the strengths and limitations of the different designs, but what are things we can do going forward to strengthen the different designs that we're working in? Maybe I'll start with Lee. What do you think are some of the things we can do to address limitations we've experienced with registries, challenges in enrollment, small sample sizes? Are there new approaches leveraging the EHR or other sources that can help us speed the registries?
It's a great question. And I think the answer is, I think that the ways today, 2023 and that's 2024, that we have for reaching patients has dramatically changed. When I think of what Lou Holmes did with the North American AED registry and how hard the staff had to work to engage patients with people exposed to anticonvulsants versus our ability to use carefully some digital social media platforms, whether it's Instagram or Facebook, and both identify groups of patients who are interested in this or using other digital platforms. I think we have a huge opportunity. I think that people who run registries have to though dedicate the resources to really developing those platforms. So, thank you.
Sonia, do you want to comment on that as well, or? Saw you nodding your head.
Okay. So I probably should have included this in my disclosures, but I work with some pregnancy registries, and I don't think they're using all of those methods as well as they could. So I think that's really important.
Just to give you a concrete example, we're doing a documentary film. It's going to call More Than Blue. It's philanthropically funded on postpartum depression. And we wanted to recruit a few more characters. And I put one Instagram post 4 days ago and got 100 responses from patients who wanted to tell their story. So I just think that we need to pivot and to get also people, frankly, when you're my age, I don't have the background in using those digital platforms the way some people do. So I think we need to be partnering with folks who really know how to leverage digital platforms and pivot it toward or point it towards recruitment so that we can get adequate numbers to make reliable estimates earlier rather than I thought Leyla's report was so well to be that far out before you have some risk estimate in which you have confidence.
Great, thank you. Are there other innovations in registries that you're adopting in terms, beyond recruitment, in terms of the content of these studies that we should be thinking about?
Well, again, going, one of the things that happened during COVID is historically we went and got medical records. They were being faxed to us, at the hospital. And during COVID, on the fly, we converted everything to digital. And so two things happened. One, it was so much easier to get the records, and so our ability to get good data we did that interval shortened, and so we're very sort of pleased, with being able to sort of get and also even though we were pleased about our procurement rate went up. So both the speed and the proportion of people who are actually providing such critical information. You can imagine you're investing in a registry and following that patient prospectively, but your outcome are those records. And so that's where the money is. And we invested sort of what was actually a modest amount to convert everything to digital procurement of good source data and then shortening the amount of time so that if we did identify a malformation, we could get that the dysmorphologist also sent digitally, and so I think that has helped huge.
I'll ask a similar question to Krista. What do you see as the innovations that are coming in database studies that could increase our confidence in the results that the studies are providing?
So before going to the innovation part itself. I think, so we have now about 15 years of experience, more or less, like working with these data sources. And I think we have learned a lot in terms of what to be careful for. Most of the work so far has really been focused on live births, right? I mean, I sort of started the presentation by saying we used this mother to infant linked live births. So, and we have been focusing a lot on congenital malformations and outcomes. One area that is sort of important in the context of studying drug safety in pregnancy that has been neglected in the context of these data sources is the non-live birth outcomes. So I think we started to look into that in more recent years. So can we study spontaneous abortions, stillbirths, and so forth? But I mean, estimating gestational age for live births is hard. It's even harder in the context of non-live births. So I think there's a lot of work to be done there to make sure that we can sort of get a good handle and sort of start looking at some of this other set of important outcomes as well. So that's one component of moving forward. The other one is, so although we can study a large number of outcomes, there are still others among the live births that we can't. And I think so far we sort of used linkage to electronic medical records and to birth certificates and death certificates, mostly in the context of validation studies, but I think there's a lot more that could be done there to really sort of make them an integral part of the data source itself and start looking at some of the outcomes that we can't get to now, or get some of the potential confounders that we might be concerned about now that are not well documented in those data sources. There's a lot of free text available that could sort of be exploited with like the newer computing power that we have available. So I think that's definitely another area that we should be looking into. And then sort of a third area is especially when we're talking about very rare exposures, very rare outcomes. I mean, it was alluded to in one of the presentations, like really pooling from different data sources, like the Sentinel is an example. We've done it in context of IMPRESS, but there's a lot of like details that become important in terms of making sure that you're truly measuring the same thing, that you're adjusting for your confounding in the same way. So I think delving deeper into how can we make these collaborations go smoothly and making sure that studies are as valid as if they're done in just an individual data source, I think is another potential area of future research.
Terrific. So we're collecting questions from our Zoom participants, so please feel free to submit questions via the chat. And the first of those is directed to Anne. And the question is, what are the ethics of simply including a pregnant person in a research study, i.e. not to exclude or withdraw from a protocol when the numbers would be too small to draw any meaningful conclusions about dosing and fetal safety?
Yeah, so I think that's an excellent question. And so when we talk about presumed inclusion, there are a lot of formats for that. One would be that you wouldn't just exclude somebody based on their pregnancy status. Another would be that you would design a study so that you had enough pregnant people that you could make some conclusion about something. And then another possible approach would be to design a pregnancy specific study. And I think, you know, different questions call for different approaches. I mean, one of the things that I think I emphasized at the end of the presentation was that there are two things that we sort of think about when it comes to the benefits of research. So one is access to direct benefit for that research participant. So I think it was really sort of hard to understand ethically why pregnant people would be excluded from an Ebola trial when they didn't have any other options for interventions, right? So that's, and even if you didn't get a lot of data there, it's there are different ways to think about how best to include those people, but to exclude them is really ethically problematic. Then you think about, you know, access to benefit for the population, and that taps into this other question. And you're going to be thinking about a variety of things, for which there's different numbers of people that, I mean, everybody on this panel knows this better than I do, but you may need smaller numbers of folks to get a pharmacokinetic profile versus, you know, capturing the risks of very rare outcomes. Well, you know, you're not going to be able to do a randomized trial and know that. But, you know, I think one of the things that happened with the COVID vaccine trial was that there really weren't any, you know, data. There were exposures that happened during the trials that, you know, gave people a tiny bit of information. But that can give people confidence about taking a drug or vaccine that really is likely to be in their best interest. And I think the last point I was going to make, and I'm about to forget it, I can tell, is I don't know. I think I might have lost it, but there, if I come up with it later, I will offer it up. But so I think different contexts call for different. Oh, I know what it is. So there are ethical questions about prospective enrollment of people on studies versus if somebody falls pregnant on a study, what do you do in that situation, right? And so the practice has generally been for people who fall pregnant on a study that you might follow their outcomes and maybe the perinatal outcomes or infant outcomes, or you might not. But it's just been in recent years that people are talking about giving people the option of staying on the study, staying on the drug. They've already been exposed. They've already been exposed in that early first trimester. So the benefits for them of you know, being removed from that drug are not clear. So it's really protective of the pharmaceutical company or the researcher or, you know, the risk aversion. So I mean, I think there is an ethics to all of this and it's complicated. So, yeah.
Absolutely. So Lee, in your presentation, we heard you talk about the really difficult risk benefit calculus that individual patients and their providers have to engage with. And I guess my question to everyone on the panel is, what research do we need to figure out how to better communicate risk and help patients weigh this risk and benefit? You know, patients generally want to know, is something safe or is it not? But you know, as we've heard from all of the presentations here today, that is often a question that can't be answered in a really direct way. There's a lot of uncertainty. The data are complex. It's hard to fully integrate all of the existing studies. Adverse effects are rare but highly consequential. So what is the science that we need to really inform those discussions and integrate all of the data that we're all generating? I don't know, Leyla, do you want to?
Yes, this is the challenge to be dealing all the time, very, very complicated. And we have to see the public health and what impacts on public health. I think for pregnancy, we have to be careful to not just focus on the risk, but also put that, you know, balance that with the potential benefit of the treatment, especially in serious disease where if you don't treat during pregnancy, then there may be serious ramifications with that individual. It may impact not only her health, but also the outcome of the pregnancy. And then, of course, you know, we always think healthy mom, healthy baby. So, I think that, you know, communication and risk always has to be placed in the context of
Yeah, I think, you know, to Leila's point, which is a terrific one. I think that we can relatively easily communicate to patients that white knuckling it, or regardless of the disorder, is a toxic exposure. And that's sort of how we frame that a woman with recurrent major depression who decides to start antidepressant and then have recurrence, that outcome is a toxic exposure, needs to be factored in to the risk-benefit decision. On the other side, you know, sort of complementing that, I think is, I think it's such a challenge for patients today, given how much information is out there. I think one thing that we can do is to help to direct patients, and these platforms exist, to places where they can get information that has been appropriately curated. Because you can just imagine what the experience is like for patients who are out there on the internet and, and they're accessing away from Krista's papers to just a case series that came out of wherever. And that can be, and so the patients don't have the capacity to really navigate that. So I think we can direct them, because we have them today, to those platforms where someone has gone and has curated to the extent possible and shared perhaps the take-home message about those data better than they could find on the report on CNN, which popped up the evening before that patient.
So we'd like to take questions from the audience. Please.
I heard about this.
Maybe try to use the mic just so the people on Zoom can hear.
Yeah, so my question is very apropos to the discussion we were just having. I loved Krista's example of the buprenorphine versus methadone. It's such a beautiful picture of results, right? Very clearly, buprenorphine is the way to go with regard to a wide range of different outcomes. But what about the setting that is perhaps common, where you have not such a clear picture, you have results on both sides of the novel, and how do you translate that? There has to be an extra step involved to try and weigh the consequence, perhaps, of different outcomes. Birth effects is a great example where we often look at specific birth effects. Often the motivation is to try and understand etiology, recognizing that pathogenesis can be very different across different malformations. But when you have findings that are all over the place, then
Krista.
I don't have the solution. But I think it's a really great question that we struggle with all the time when we're working on our studies. And I think it's at different levels, right? So there is like conflicting information when looking at a given outcome. And then there's also different findings depending on which outcome that you're looking at, right? And we were talking about how to communicate that to patients, and maybe we could sort of direct them towards some more curated sites. But I think even like for us as like the scientific community and providers, I mean, before we even communicate to patients, how do we make sense of all of this information? One thing that we sometimes try to do is, because like as was mentioned before, like one single study is never going to give the answer. Like when you're having a study and there's already evidence in the literature, maybe try and sort of do a systematic review and add sort of a meta-analysis that sort of shows in which direction the cumulative evidence is going, making sure that you include the studies that you feel are well-designed studies, to sort of try and sort of see over time where does the evidence start to land.
I just want to add that so in addition to considering all the evidence, I think you also have to take every situation, every patient is different, so you have to take the overall context of the patient situation. So for these comparisons, buprenorphine versus methadone, certain outcomes were assessed, and we saw that buprenorphine had better outcomes, but the individual patient, right? Buprenorphine might not be the best treatment for all patients, and so I think you have to keep that into consideration. And I think, there's the initial trial, the mother trial, showed that there was a large dropout rate in the buprenorphine arm because, there was a higher rate of withdrawal on buprenorphine in pregnancy compared to methadone. So these are really, really complicated considerations. So it's not just, again, it's not just looking at the risks, taking the overall context of the benefit of the individual treatment of the individual.
Krista.
Just wanted to add something to that, and consider that, of course, all that information can be conveyed in like a 15-minute presentation, but like we were very careful, like that the patient to conclude that. So the conclusion was not like all patients should be switched to buprenorphine because buprenorphine is doing better, but it's just like buprenorphine isn't often the treatment option that is available. Not to say like any patient that does well should be switch to be more. It's just like adding something to the other material, which I think is a nuance that is all.
Sonia, did you want to comment on that?
I just want to make the comment that I think it's important for patients, as we're talking about these sorts of things, that you need to make the point of relative risk versus absolute risk. Because I think oftentimes, you know, if we have a rare birth defect, it triples the risk of rare birth defect. People think, oh my gosh, it triples the risk. Oh my gosh. And then you say, well, it goes from 1 in 10,000 to 3 in 10,000. You know, still most likely it's better for you to be treated for your depression than to not be treated for your depression for that kind of absolute risk. The other thing is to remember, and we certainly know this from the COVID pandemic, is that people don't understand numbers. The general public doesn't understand numbers. And I do think, you know, I saw something on my Facebook memories today that I had shared during the pandemic of, you know, how many people were in the hospital and how many of those, they had little dots, how many people were in the hospital and then how many had been vaccinated. And I thought it really made the point that I think a lot of people didn't get, well, I got the vaccine, I still got COVID. Well, did you end up in the hospital? Did you die? You know, so I mean, I think those sorts of ways of showing things, it's important that we try to figure out, and I think as you implied earlier, trying to study those things, what are the ways to get across to people those sorts of issues? I think, you know, people aren't comfortable with science at all anymore, I think, and then they're not comfortable with numbers either. And how can we help people to translate things they don't feel comfortable with into what they need to make their own decisions?
Alec.
I have a question in data. In Krista's presentation, the effects of early and late exposure appear to be almost superimposed. And that's honestly the context of these exposures. And I'm wondering if it gave you loss.
Thank you for the question. It's a really good question. It didn't give us pause in this case, just because of how the treatments are used. And again, it's something we didn't have time to go into, but like once patients are on these medications, they tend to be treated throughout pregnancy. So if you remember right when we were showing the numbers with exposure, early pregnancy, late pregnancy, they're almost identical because very, very few people actually discontinue or switch medication. So for this particular example, for the late exposure was almost the identical same people, which is why we're basically measuring the same effect. But in other contexts, it's very different, right? For the context of congenital malformations, for example, where we know it's really focused on the first trimester, we'll use the second or the third trimester. That's like the negative control, because if we see exposure there, and we hadn't seen exposure in the first trimester, there's still an increased risk, then we know we're dealing with residual compounding, right? So, but in this particular case, because medications are really used on a chronic basis, that's the reason why it's fine.
Thank you.
Other questions?
Rare diseases, and it's quite tricky to find patients and the data ultimately. And especially one of those diseases called CDPP or congenital pulmonary pregnancy is one of the triggers for getting the disease onset. And when looking at the guidelines from not only the FDA, but also from other regulatory bodies, usually, as you presented earlier, pregnant women are excluded from the trials. And it was the question, keep them or not. And the other question that we then encountered was that effective contraception methods needs to be included into the language for the participants for being part of the trial. So at the end of the day, we are into a situation in which those patients need to be excluded, so to say, from the trials. And although perhaps larger authorities have also evaluated the benefits versus the risks, the other bodies that are giving their opinion are the IRB bodies from each of the institutions. So if you have any advice on how to navigate this problem and how to best collect the little data available besides registries, that would be great.
Well, I mean, I think that I can speak to the question about IRBs. So I think IRBs have tended to wonder whether it is their responsibility to raise questions about, you know, whether pregnant people should be included in a study, and have also you know, tended to think it's their responsibility to sort of stay on that side of the slide that had the purple circle that said research, and to eliminate the gray circle of risk within it. And so I think, you know, the second wave and work that's been going on since has been really working to sort of revise the ways that IRB folks think about what their responsibilities are, and to really foreground that there are ethical problems around exclusion. And you know, one of the things that we have learned is that there's a lot of misconceptions about, for instance, what the federal guidance allows in terms of inclusion of pregnant people in biomedical research, and they're actually very permissive of their inclusion. So, you know, I think there is a role for an ongoing conversation about that. One of the things that we have noticed and heard is that conversations go better on IRBs when there's somebody who is trained in OBGYN, who's used to thinking about the risk trade-offs that are part of pregnancy, who are used to thinking about, you know, imposing risk on pregnancy. And so, you know, one approach is just to ask an IRB chair whether there is an opportunity to include somebody with that specific expertise on your institutional review board, which can have an outsized effect. And our group has published a lot that I think can potentially move some IRBs in the right direction too.
Thank you. So this is from the Zoom audience. So reflecting on Sonia's talk, when do we need risk minimization programs for teratogenic drugs, and when would labeling be adequate to communicate the risk? Maybe Leyla can also weigh in on that.
That's really challenging, and I think I do think that oftentimes labeling isn't enough. You know, I think if it's something that is a significant tragedy and it's something that's used by women of childbearing age, I would argue that we need more. We have seen a lot of exposures to certain medications, and who reads the label? I take several medications. I don't read any of the labels, so I doubt that most persons that are potentially pregnant read my label. But you've got to weigh that. I mean, just as I was saying earlier, I think it's really hard for the FDA. You don't want to make it so difficult that at that meeting, just for a second more, at that meeting in March, I don't know if this worked. I don't think so. I think it's working. Is it okay? At the meeting in March at the FDA, there was a whole group of dermatologists that were really up in arms of iPledge, that they feel like iPledge is keeping some of their patients from being able to access. And you know, I have a child that was on Accutane. It is really complex. You have to know that on this date, you've got to get that pregnancy test, and you've got to say that you're taking these two, you know, birth control methods. It's complicated. On the other hand, you know, so I think it's hard, and
it may be easier in cases where, like, isotretinoic acid, where it's a very strong teratogen. But what about valproic acid, which is, you know, is a pretty clear teratogen, but not as strong a teratogen?
Yeah, I think it's really complicated. I think that for something like isotretinoin, again, it comes down to kind of benefit risk, and so when you weigh, I mean, people do have different opinions on the benefit risk considerations for using isotretinoin in females with reproductive potential, because people say, well, acne is not a life-threatening condition. And so that's why there is really a need for REMS, because there is a need for the population to understand the serious risks. And you're taking something for acne, you're not taking it for a serious life-threatening condition. So so I think these kinds of considerations come into play in terms of decision making for the need for REMS.
Not just the risk, but the benefit as well, as you were.
Yeah.
Oh, Lee, did you want to?
Trouble with it, just
Like that.
I love the example, sodium valproate, because I don't know why there isn't a REMS for sodium valproate. In our center, we think that the use of sodium valproate in reproductive age women should absolutely be contraindicated. We think it should be sung from the rooftops. We think that we should be following our colleagues in the EU, who have been much more restrictive. And so I agree that bipolar disorder is not acne, but if it's not, then we should be doing acne more in certain settings than we are.
In the back.
First of all, thank you for your response right now. I have two questions for anyone, but the first one I'm curious about for Dr. Cohen. You mentioned that people make different decisions with the same information. And I'm curious if you could shed any light on what sort of specific information or risks or side effects researchers focus on that would be most likely to help people to inform their decisions to change their decision making. And then secondly, a lot of the series talked a lot about case series and sort of small studies and being really informative. And I'm curious if so you could talk a bit about the risk of false positives or biased study results. I'm thinking here particularly about Dr. Leyla's work on here, but I'd be curious for other examples of how we weigh like the potential for getting valuable information.
Fantastic question. And so in a way, your first question has sort of two parts. And sort of the first part is sort of what do you include, which is I think where you were going. And so what we try, I was speaking before about curating information. Over the last 15 years, we have so much more information in the reproductive safety space that it becomes quite a challenge in the context of a consultation to sort of figure out what the what the most critical elements are. But we do that as a group, and we sort of figure out in advance what are the issues that we think are critical to be shared with patients about everything from teratogenicity to neonatal effects to the small amount of information, the sparseness of data on long-term neurodevelopment problems. So I think it is it's very possible to curate the amount of information that you should be sharing with patients. But I'll also say that we did this systematically. We put it on sort of like an MP3 so that every patient had exactly the same information. And we were struck by the fact, and we were pleased that that patients weighed those risks and did that calculus in sort of a private way, leading them to make different decisions. I hope that answers your question.
I mean, I'm happy to jump in on the part two of it. So I think signals are a really challenging, sort of issue to deal with. And I remember when we were working originally on trying to get the research community to think about inclusion of pregnant people in vaccine development efforts for Zika virus vaccine, right? And really they weren't included in that, even though them getting Zika was the route to microcephaly. And one of the arguments against that was, what if we saw a signal, then it might shut down the study and wouldn't be able to get the vaccines out to people who needed them most, including women of childbearing age. And I think it is a real concern. I think it's an important concern, but I think that the response, and this relates to the dolutegravir story too, is not to do the research. The response is to figure out how to responsibly communicate those signals so that people can integrate what those findings are into an informed decision, whether that is, you know, one of the things that I had learned recently is that the way that some of these studies are titled is very neutral, right? Association between X exposure and adverse perinatal outcomes, which when you are worried about adverse perinatal outcomes, if there is no association between exposure and outcome, a neutral title does not communicate neutrality. It communicates, you know, alarm and risk. So really I mean, I think there's some amazing work being done on risk communication now. And I think pulling that into the pregnancy space, pulling that into the research in pregnancy space would have an outsized impact on sort of confidence in doing these studies and confidence in sharing the results.
Krista.
I'd also like to answer, you mentioned like the concerns about like false positive, and I think there's a distinction between like, is it due to the fact that it's just like a chance finding, or is it due to the fact that it was like a poorly conducted study, right? And hopefully, like we know enough and have enough understanding to help us read out the poorly conducted studies, but that still leads to chance findings. And I think there's a couple of things we can do, right? So what we've tried to do, and it's not always possible because the data aren't always there, but if we study like an exposure and outcome, that is like the first time that is being evaluated and we find a signal. So what we've tried to do is before sort of getting that out there in the literature and potentially cause alarm, see whether we can immediately try and replicate it in another data source. If it's the first time, we try and replicate it right away. So we've done that in collaboration with like our collaborators in Scandinavian countries who have the registries before we publish, sort of using the same design, do you see the same thing or not. We've also actually done it in the context of a collaboration with Dr. Cohen, where it's really cross data sources. So together with our colleague, Dr. Marie Stroud, who's also here, so we're using sort of more of a scanning approach to sort of see whether when we're looking across a whole range of potential adverse outcomes, whether we're picking up signals, and in this case, it is for antipsychotic medications. And so we picked up a signal that has not previously been reported. We hadn't seen it. Because we used all the data in our study, there was like nothing we could do in our data. So we actually reached out to Dr. Cohen, who has the registry with the antipsychotic medication as well, to sort of see like, does he see the same in the registry or not? If yes, then maybe we're concerned. If not, then it is potential that it is like a chance finding. So I think there's a couple of things we can do before sort of putting the information out there and potentially creating some concern that is unnecessary.
You know, Brian, you asked before, sort of where's the field going, and sort of, and you really Krista about crosstalk between you know, folks with different sorts of data, which I think is really going. But it's unusual to get a bioethicist and pharmacoepidemiologist in the same room, let alone sitting. So I want to just sort of go one step further, because I'm familiar with sort of a little bit about the methods that you use, Krista, when you talk about doing the deeper dive. And to, you know, sort of in a way doing sort of a validation. So if you see a signal and then you want to sort of look deeper at a group that you choose from the cohort, I was wondering when we talk about the EHR, Brian, you were sort of asking, you know, where's the EHR committed? If we in IRBs, what's the ethics in a way? If you had the ability to sort of look to use the EHR to identify exposures, to then really, you know, so what is the ethical way to engage patients in research to answer such a some of these sort of very important questions, if that question makes sense, because you know, you may have permission, but sort of how far does that permission go? But in a way, Chris defines the signal in an EHR data set that she has access to because it's anonymized. How do you then go and try to sort of do it one better and actually doing a deeper dive with a subgroup of those patients? How do you do that?
And we're at time, so just if you can solve that conundrum in 20 seconds or less, that'd be great.
Great question. I think with these big databases and the access to data that we are going to be increasingly having, there are new models of ethics that are different than our traditional informed consent model, that are being discussed, that are being thought through. you know, the ethics of the learning healthcare models. For instance, folks here in Hopkins have been doing great work with that. And I think that's really going to be informative when we think about, you know, responsibly, you know, delving deep and communicating what we find.
Terrific. Well, I want to thank all of our speakers again and thank all of you for joining us here.